let's talk about the space where a PI3 kinase mutation is found. So that's on the sequencing, they've progressed in their first-line therapy. What features of the disease and goals you want to achieve take into account as far as picking a therapy for that next option?
That's such a good question. We know now from multiple trials that those patients have worse outcomes compared to the wild type patients, right? So we want to be very proactive about identifying those patients and proactive about bringing in targeted treatment that hits the pathway if we can. One of the primary things, of course, is how did they do with endocrine therapy in the frontline setting, right? So some of those patients are going to have such aggressive disease biology that they may have primary endocrine resistance or don't really respond to the combination of endocrine therapy and CDK4/6 inhibition, and really at the time of first restaging they've already progressed. And even though we want to bring targeted agents to those patients, I might be quicker to look for an ADC in that type of a patient. But for patients who've had some meaningful disease response in the frontline setting on endocrine therapy, even if it's not the median PFS, but they've had some disease response, at least 6 to 12 months, I'm inclined to stick with the endocrine therapy approach and really bring in a targeted agent with the hope that we can maintain them on endocrine therapy for some time longer. And we've had such success with some of our PI3 kinase agents that we are very inclined to give it a try if we can.
Yeah, I'm glad that you brought up endocrine refractory disease, because that is something that still happens. And in that select group of patients, I do think that I would take the same approach as you, is not necessarily jumping towards a targeted therapy option if they truly had progressed immediately on their first-line therapy of CDK4/6 AI. For these patients who have what we would consider endocrine sensitive disease, do you feel differently if, say, they had a PI3 kinase mutation versus an AKT versus a PTEN mutation?
Well, I might think about it a little bit when I select treatments, right? We have multiple agents available to us. A lot of our treatment selection is based on toxicity, and which I'm sure we'll get to is a very important topic. We know these agents carry unique toxicities, and we really have to think about them in the context of each patient. But, when I do see a PIK3CA mutation, I always do pause and think, do I want a direct PI3 kinase inhibitor? Because that is an on-target agent as opposed to a more downstream agent. Now, that comes generally with added toxicity, and it's always a balance of the toxicity versus the efficacy. Certainly, if I have downstream alterations, PTEN or AKT, I'm inclined to sort of go with AKT inhibitors. They tend to be a little bit better tolerated and are certainly efficacious at hitting those alterations.